type 2 diabetes and heart failure. Here are my disclosures. Let me start by saying that diabetes is one of the most common non-communicable diseases. Cardiovascular disease is the most common cause of death, and management of a cardiovascular disease in diabetes is a great challenge for the physicians and the cardiologists. So, according to International Diabetes Foundation, in 2021, we had approximately 5,037 million adults that were living with diabetes. The total number of people living with diabetes is projected to rise to 643 million by 2030 and 7,183 million by 2045. Almost 1 in 2 adults living with diabetes are undiagnosed. Diabetes causes 6.7 million deaths. 541 million adults have impaired glucose tolerance, which places them at an increased risk of developing type 2 diabetes. Also, diabetes causes at least $966 billion in health expenditure. More than 1.2 million children and adolescents are living with type 1 diabetes, and 1 in 6 live births are affected by diabetes during pregnancy. In our part of the world, in Europe, 1 in 11 adults are living with diabetes. The number of adults with diabetes is expected to rise to 67 million by 2030 and 69 million by 2045. Over 1 in 3 adults living with diabetes are undiagnosed, and 1.1 million deaths due to diabetes in 2021. We all know that the natural history of type 2 diabetes, by the time of the diagnosis, we have at least 10 years, prior years of pre-diabetic conditions with all the micro and macrovascular complications. This is very important because in a meta-analysis of 18 clinical trials evaluating the risk of cardiovascular disease among patients with impaired fasting glucose and impaired glucose tolerance, found that both types of these pre-diabetic conditions increase the risk of cardiovascular disease. And the mechanism by which diabetes leads to coronary heart disease, we know about hyperglycemia, we know about insulin resistance, dyslipidemia, thrombosis, inflammation, and infection. All these cause subclinical atherosclerosis, which have the disease progression to atherosclerotic clinical events. In the USA, we had in a study, we found out that people with a history of diabetes and cardiovascular disease had an increase in total mortality. People with diabetes die earlier, and cardiovascular disease die earlier than those of without diabetes. We see that with diabetes, it's -6 years, but with diabetes and cardiovascular disease are -12 years. In the UKPDS study, it was proven that the increasing value of HbA1c increases the risk of cardiovascular disease. When looking at the distribution of initial presentation of cardiovascular disease, we see that heart failure is the second most common. Patients with heart failure are at risk for morbid and fatal events. As many as 1 in 5 people will develop heart failure during their lifetime. It was estimated to affect 64 million people worldwide in 2016. Heart failure morbidity and mortality rates are high despite advances in therapy. In the US, the 5-year heart failure mortality after diagnosis was approximately 50%. Heart failure mortality risk is similar to some of the common cancers in both men and women. So, but when we're talking about heart failure, we're talking about the new universal definition, which classifies the different phenotypes according to left ventricular ejection fraction. So we have heart failure with a reduced ejection fraction when the left ventricular ejection fraction is less than 40%. We have heart failure with mildly reduced ejection fraction where the left ventricular ejection fraction is between 41 and 49%. And heart failure with preserved ejection fraction when the left ventricular ejection fraction is more than 50%. So the guideline-directed medical therapy base for heart failure, we had the three different blockages with RAS inhibition, which decreases afterload and blunts neurohormonal response, beta blockage, which decreases the work of the left ventricle and blunt neurohormonal response, and mineralocorticoid receptor inhibition with diuresis and blunts also neurohormonal response. But we see in studies both in the US, Sweden, UK, that even with the titration of the guideline best medical treatment for heart failure, we have the infrequency and very few patients achieving target doses. So in 2022, we have the American Diabetes Association that published the new guidelines with the standard of medical care in diabetes, which said that heart failure is another major cause of morbidity and mortality from cardiovascular disease. Studies have found that rates of incident heart failure hospitalization were twofold higher in patients with diabetic compared with those without. People with diabetes may have heart failure with preserved ejection fraction or reduced ejection fraction. Hypertension is often a precursor of heart failure of either type, and atherosclerotic cardiovascular disease can coexist with either type, whereas prior myocardial infarction is often a major factor for heart failure with reduced ejection fraction. For prevention and management of both atherosclerotic cardiovascular disease and heart failure, cardiovascular risk factor should be systematically assessed at least annually in all patients with diabetes. These risk factors include duration of diabetes, obesity and overweight, hypertension, dyslipidemia, smoking, a family history of premature coronary disease, chronic kidney disease, and the presence of albuminuria. This picture taken from the guidelines has as the base the lifestyle modification and diabetes education, where I should add the exercise. And we have the 4 pillars of glycemic management, blood pressure management, lipid management, and agents with cardiovascular and kidney benefits. My talk today is going to be focused on the glycemic management. So, metformin. Restrictions to use of metformin in patients with medically treated heart failure were removed from the FDA in 2006. Observational studies of patients with type 2 diabetes and heart failure suggest that metformin users have better outcomes than patients treated with other antihyperglycemic agents. However, no randomized trial of metformin therapy has been conducted in patients with heart failure. Metformin can be used for the management of hyperglycemia in patients with stable heart failure as long as kidney function remains within the recommended rates of use. Sulfonylureas and thiaglitazones. Given the lack of data of any demonstrable benefit, sulfonylureas are not recommended as initial therapy in patients with stage C heart failure with reduced ejection fraction. Data on the effects of glucose-lowering agents on heart failure Outcomes have demonstrated that thiaglytazones have a strong and consistent relationship with increased risk of heart failure. Therefore, should not be used, should be avoided in patients with systematic heart failure. DPP-4. There were recent studies examining the relations between DPP-4 inhibitor and heart failures with mixed results. Saxagliptin, where the people taking saxagliptin were more likely to be hospitalized for heart failure than those given placebo. On the other hand, the alogliptin, sitagliptin, elinagliptin did not find significant increase in risk of heart failure hospitalization and are considered neutral for patients with heart failure. GLP-1 receptor agonist, while there was no increased risk of hospitalization for heart failure in all the trials that were reported. So also, in particular, READER trial reported a trend towards a reduction in heart failure hospitalization and can be used with safety in people with diabetics with heart failure. Insulin. In patients with established heart failure, there is little evidence about the safety and efficacy of insulin use. No RCTs have been conducted with insulin in patients with heart failure, and lots of observational studies are often confounded by indication as insulin is more likely to be used in patients with more advanced type 2 diabetes or severe comorbidities. The ORIGIN trial saw no impact of basal insulin glargine on cardiovascular outcomes and heart failure events in patients with cardiovascular risk factors in comparison to standard of care. Given insulin's correlation with hypoglycemia and weight gain and lack of demonstrable cardiovascular benefits with use, other agents such as metformin as SGLT2 inhibitor should be preferentially used. Only when we cannot achieve the lowering of glycosylated hemoglobin, then we might add insulin. The new guidelines from ADA had the heart failure column add between the atherosclerotic cardiovascular disease and chronic kidney disease, in which it states that SGLT2 with proven benefit for this population. The European one on the right side is still the same, remains the same. So let's talk a little bit about SGLT2s. The first study was EMPA-REG, which was the first CVOT to report cardiovascular outcomes for SGLT2 inhibitors. And not only the investigators noted a significant reduction in a 3-point MACE comparison with placebo, but also we have significant relative reduction for cardiovascular death, 38%, heart failure, 35%, and all-cause mortality, 32%. The second one was the CANVAS program, where canagliflozin was reported to demonstrate superiority for 3-point MACE with its use found to result in significant reduction in cardiovascular death and heart failure, hospitalization for heart failure. Subsequently, similar observations were made in the CREDENCE trial, in which canagliflozin use was associated with a significantly reduced cardiovascular death, myocardial infarction and stroke, and hospitalization for heart failure. Then we had the DECLARE TMI trial, where we investigated the use of dapagliflozin and demonstrated a non-significant reduction in the rate of 3-point MACE and a significant lower rate in hospitalization for heart failure in people with type 2 diabetes. So then follow up the DAPA-HF study, which explored the use of dapagliflozin in people with or without underlying type 2 diabetes and heart failure with reduced ejection fraction. Then there we found that we have a significant relative risk reduction versus placebo for cardiovascular death and worsening of heart failure. And it was an important study because here we found out that the population were about 55% non-diabetic. So the DAPA-HF summary provided a statistically significant and clinical meaningful reduction in the composite of cardiovascular death or worsening heart failure events and improvement in heart failure symptoms. Dapagliflozin was the first SGLT2 inhibitor approved for heart failure with reduced ejection fraction, both in patients with diabetes and without diabetes. Then we have the Emperor reduced with empagliflozin, which also proved that we have the educated cardiovascular death and heart failure hospitalization. We had first and recurrent heart failure hospitalization, and we had an eGFR slope benefit. So as a bottom line, up to these studies, we found that SGLT2 inhibitors in heart failure with reduced ejection fraction provided 30% reduction in all-cause death, 40% reduction in cardiovascular death, and 26% reduction in heart failure hospitalizations. Then we have the Emperor Preserve study, which was like a phoenix for the beginning of the new season for trials in heart failure with preserved ejection fraction. Then it shows the significant benefits of pharmacological intervention on top of standard of care for heart failure with preserved ejection fraction. And it was designed with a placebo. The patients had left ventricle ejection fraction more than 40%. And the endpoints were confirmatory for educated cardiovascular death or hospitalization for heart failure. The secondary endpoint was educated first and recurrent hospitalization for heart failure. And we had a confirmatory slope for the eGFR slope. Followed, it was the Impulse trial, which was specifically designed to see the in-hospital initiation of empagliflozin in patients hospitalized for acute heart failure, regardless of left ventricle ejection fraction, which, as you can see here, all the trials of empagliflozin, which concluded that patients hospitalized for acute heart failure treated with empagliflozin were 36 more likely to experience a clinical benefit versus patients on placebo. The clinical benefits were consistent in patients with heart failure with reduced ejection fraction, heart failure with medium ejection fraction or preserved ejection fraction, and in patients with the de novo or decompensated chronic heart failure, was well tolerated with the overall safety data consistent with all the previous studies. So this study concluded with empagliflozin being added to all types of heart failure for treatment for all types of heart failure. So as we can see here in the slides, with the treatments, it started for reduced, and now it's with all types of heart failure from all the cardiological societies. But what are the key physiological effects of SGLT2 inhibition? We know that it decreases glycosuria, which decreases HbA1c overall. It decreases the glycotoxicity and reduces body weight. Also, with increases natriuresis and increases osmotic diuresis, which decreases plasma volume, blood pressure, and glomerular hyperfiltration. This diuretic effect is selectively reduces interstitial volume with minimal change in blood volume. There are no counter-regulatory stimulation of the RAS and no activation of the sympathetic nervous system, no hypocalcemia, unlike the loop diuretics, improves renal function, and reduce of uric acid levels. The proposed mechanisms of action for heart benefit, for heart failure benefits, the decreased pre and after load, the improvement in cardiac metabolism, the myocardial pump with potassium and exchange inhibition, decrease cardiac fibrosis, and decrease inflammation and epicardial adipose tissue. So in 2021, we found that SGLT2 inhibitors were added to the standard of treatment with the ARNI and beta blockers and diuretic agents. And in 2022, in cardiology, the best, the guidelines treatment added SGLT2 inhibitors. So this is a slide that shows all the anti-glycemic drugs and which are recommended or not for treatment of heart failure. I think that this concludes my speech today, and I hope that you will enjoy the sea, the sun, and the speeches from the other speakers the next few days. Thank you for listening to me.